One is supporting the yes, the nuclear medicine specialist, Dr. Valentina Garibotto from Geneva, and the second option, no, radiation oncologist, Professor Alberto Bossi, and we have Valentina here with us.
Yep.
Welcome. The floor is yours.
Thank you very much. I thank the organizer for inviting me and for giving me this title. I'm very happy to defend why yes. And I also allowed myself to change a bit the title, so I think that yes, PSMA and MRI should be performed in high-risk prostate cancer. They should also guide our treatment algorithms, but we have to keep in mind that PSMA and MRI perform better. They're the best diagnostic tool we have now, and so they're better than the standard of care we had before. No disclosures related to this content. Oh, I have no voting. And so, but I hope you will vote yes as well. And I can stop my presentation now because I'm telling you already why. Why it is more accurate, it is according to current guidelines, and then if we do it, we will collect the data to build evidence-based treatment recommendation in the future. Let me go a bit into the details for these 3 points. The accuracy of the diagnostic tests, so MRI and PSMA, has been proven in multiple studies. I'm referring here to a recent randomized controlled study in which PSMA was compared to conventional imaging, meaning CT plus bone scan, and you see that the overall accuracy is higher, specificity is higher, sensitivity is higher, rate of inconclusive or equivocal finding is lower, so it's better. And this can be exemplified in multiple individual cases. Let me just show you one we recently had in Geneva, a patient that was stratified on the basis of bone scan, in this case SPECT CT, and thoraco-abdominopelvic CT. On the basis of these features, this patient with a Gleason 9 and a PSA of 13 was CN0 and CM0, operated. After surgery, we find positive lymph nodes, relevant PSA postoperative, 11 nanogram mil, and we do a PSMA 3 months later that clearly shows nodal metastatization plus nodes that go up to the thorax and the supraclavicular fossa, so clearly an M1 patient on the basis of the PSMA finding. This accuracy, so this upstaging, is related to established risk factors for an aggressive pathology. So we know that when we upstage, we're not seeing, something that does not have a biological relevance, but we see the disease. And we also know that when we have positive findings on PSMA, the risk for biochemical persistence after radical prostatectomy is higher. So it's a predictive of outcome. It is not perfect. So I read the literature, and there is, of course, a lot of criticisms about what we cannot see with this improved imaging modality. The sensitivity, if we use histology as standard of truth, of course, is fairly low. It's 40% in multiple series, but it's still largely higher than what we can get with CT, not going above 15%. And to compensate this, we can use risk stratifications on the basis of the biological characteristics of the tumor. So if we know that it's a very high-grade tumor and still the results on PSMA are negative, we can estimate what is the risk that we're missing the disease. The specificity is very good. Still, of course, it's not perfect. We have false positive findings also with PSMA. But again, the important message here is that we have a rate of false positive finding that is much lower than the standard imaging we have. So, for example, for bone scan, here I'm referring to a recent meta-analysis, the values of specificity do not go above 70%. The guidelines. The NCCN recommends using PSMA imaging and not necessarily passing through bone scan and CT for high and very high risk. The European guidelines also include MRI and PSMA, of course, with the caution that when using PSMA, we should be aware of lack of outcome data on subsequent treatment changes. Also, the consensus on advanced prostate cancer includes, despite lacking full consensus, but a majority of panelists voting for PSMA PET in high-risk localized prostate cancer, and the fact that PSMA should be combined with multiparametric MRI in these population, and that bone scintigraphy should not be added additionally when you have the PSMA information. Of course, this is what we know about the diagnostic performance. We don't have the data on the impact on outcome. How can we build it? If we look back at the evidence we have for the modality for which the evidence is there, so bone scan and abdominal CT, we see that this evidence came from including these imaging modality into prospective studies and collecting these evidence on the basis of registry data, for example. So the strategy I suggest for collecting the data, both for MRI and PSMA, is to do just the same. So to include these imaging modalities into ongoing and future prospective studies, and to include them into clinical practice that will then nourish registry data. And this is indeed ongoing. There are multiple ongoing and future studies, ongoing studies that already included PSMA and MRI into their stratification of patients. And in clinical practice, we see it probably in the majority of the centers you are working in. PSMA has already its place in clinical practice. So in summary, I think that yes, we should do PSMA and MRI in high-risk prostate cancer. We should do it mainly, when possible, integrated into prospective clinical trials, and in clinical practice wherever possible, contributing to future registry data. And we should integrate it into the therapeutic management process, of course, keeping in mind that we are progressing, that we are going further, that we have a better tool with better diagnostic performances. So we switch the light on, the light is on, let's progress together.
Thank you very much for this very interesting talk. So now we hear about the no, which is supported by Alberto Bossi.
I leave you. So we always say thank you very much.